Glaucoma Webinar 2022. I'm Dr. Pushpa Raman, Ophthalmologist and Glaucoma Fellow from Hospital Selayang, and I'm going to be the moderator of the day. We are from the organizing committee of National World Glaucoma Week 2022, delighted to invite you to our first hybrid webinar, a valiant attempt to gather a small group of ophthalmologists as we are emerging from this pandemic. I really thank everyone that turned up today, physically and virtually. For the housekeeping notes, all the talks are recorded and playing live on our official YouTube channel, which will be available for free access later. During the presentation, you can use the Q&A box at the bottom of the screen to ask questions. We will try to address as many questions as possible in our available tight schedule. This event will not be possible without the support of our generous sponsor, DKSH Holdings, Malaysia. We use this opportunity to extend our thanks for their support. Now, I'd like to invite Prof. Shamsia Mohammadin, the head of Ophthalmology Department from UKM, acclaimed glaucoma specialist, to give us the welcome address.
Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon to everyone who are joining us today for our first ever Tripartite Glaucoma webinar. This event concludes our World Glaucoma Week, which has been the event highlight throughout the week from 6 to 12 March. And we conclude the whole week by inviting glaucoma experts from the region, from Indonesia and Singapore, and we have a special appearance by our keynote speaker, Dr. Rydia Lim from Australia. And we're very excited to share with you their insights into glaucoma and how they manage glaucoma in their own respective field. So I would like to thank the organizing committee headed by Dr. Pushpa Raman for her tremendous effort in promoting as well as organizing the Tripartite Glaucoma webinar, and I'm very proud to have all the 4 speakers with us, and I hope it benefits all the audiences, be it general ophthalmologists or glaucoma specialists alike. With that, I thank the organizing committee, and I hope that all of you in the audience will enjoy our webinar today. Thank you.
Thanks, Prof. Shamsia. Without further delay, I'd like to introduce our keynote lecture speaker, Dr. Rydia Lim. Dr. Rydia Lim is an outstanding glaucoma specialist from Sydney Eye Hospital and the director of Hunter Street Eye Specialists in Sydney. She's the vice chair of Australian and New Zealand Glaucoma Society and head of the glaucoma unit at Sydney Eye Hospital. She has a master's degree in public health and has been involved in glaucoma fellowship programs and trained many glaucoma specialists, especially from Laos, Cambodia, and Vietnam. She has been recently honored with Gillies Medal by the NZEX committee. I have been fortunate enough to have known Dr. Rydia Lim, a great mentor, advisor, idol, who taught me more than glaucoma. It's a great pleasure for me to invite Dr. Lim to deliver her talk on patient-centric glaucoma care. The stage to Dr. Lim.
Thank you so much, Pushpa. Let me just share my slides. Happy Glaucoma Week, everyone.
Dr. Lim, happy Glaucoma Week to you.
Can you hear me?
Yeah, we can hear you very well.
Thank you for the Glaucoma Societies for the invitation to speak at the Tripartite Glaucoma webinar today. Greetings from Sydney Eye Hospital, where I work and where I had the pleasure of training Pushpa. My talk today will be on patient-centric glaucoma care. I thought this would be a good topic as we are celebrating World Glaucoma Week. Glaucoma outcomes are different things to different people, depending on your point of view. To the scientists, it may be retinal ganglion cell apoptosis. To clinicians, it's an optic neuropathy with characteristic changes to the optic disc and field. To the healthcare system, it's about trying to fund an ever-increasing chronic disease. And to the patient, it's really about other things, and it's really about their quality of life. So what is our mission as an ophthalmologist? It's really to look at patients' overall health, preserve visual function, avoid visual disability in patients' lifetime, and use the available evidence to balance the therapeutic index, the benefits versus the risks, in an alliance with the patient, and to achieve good outcomes for all, particularly the patient, and to do it with empathy. So what is empathy? Practicing with empathy means to really see the patient in front of you, the person that they are, and also see the situation from their point of view. Who is the patient in front of you? They are a father, a worker, a person with interests. Really know your patient. Glaucoma is a lifelong disease, and that gives us the opportunity to get to know our patients really well. Your perspective differs from the patient's. As clinicians, our focus has been on clinical outcomes, pressure, disc, field, response to treatments. We have to realize that these are surrogate endpoints, and the patient's perspective is quite different. They're concerned with their overall function, their experience of side effects, fears and anxiety about loss of visual function and disability. The 6 and 9 look equally correct from each side. Patients reported outcome measures, PROMs, should and have become more routinely used in recent studies. We can see that these major glaucoma studies, the LIGHT, TBT, TAGS, and more, that patient-reported outcomes are at the front and center of the measure of success. This is a really good thing. With that in mind, what are some of the questions that patients ask during their glaucoma journey? These 6 questions are common questions asked by my patients. Do I have glaucoma? Do I need treatment? More treatment? That treatment? Am I getting worse? Will I lose my function? Will I go blind? What can I do? So I decided to think about these and go through each of them for you today. It seems like such a simple question, but do I have glaucoma? As we see so many patients as glaucoma suspects, I think it's important to not label anyone as having glaucoma until you have definite diagnosis. This study by Oddberg et al. Showed that the majority of patients experienced negative emotions with the diagnosis, and this led to an immediate reduction in their quality of life. Many feared blindness, even though 44% had no visual field defect. Fortunately, as shown in the Digit study, this fear decreased with time. And I think this has much to do with the establishment of the patient-doctor therapeutic alliance. We still have the major problem of undiagnosed disease. In Australia, now many years ago, the Blue Mountains Eye Study, the Melbourne Visual Impairment Project showed that 50% of the glaucoma was still undiagnosed. This, of course, is even higher in developing countries. raising awareness of glaucoma and perhaps having every adult ask the question, do I have glaucoma, would reduce the late presentations and the consequences of this. We also need to be aware of overdiagnosis, and diagnosis has been historically driven by technology. And so we should be aware of red disease. Also, don't forget mimickers of glaucoma. Differentiating real disease from red disease is a clinical skill. So don't over-rely on technology. Remember, artifacts and red disease are common. Here you can see real disease on the one eye and red disease on the other. Is it real or is it an artifact? Always ask yourself that. And find corroborating evidence that leads to the diagnosis. Red disease is amplified in unusual eyes and myopic eyes, two common scenarios. In eyes when you sometimes need the help most, such as myopic eyes, the question of whether it's glaucoma, the testing can often be the most inconclusive. So question number 2 is, do I need treatment? Where is your patient in this graph? That's the question I ask myself. What is their age, their life expectancy, their general health status? Will treatment do more harm than good? How bad is the glaucoma? At the initial stage, there's no real idea about the rate of change, and only time will tell. One very important thing to remember is do not overtreat patients unnecessarily, but also do not undertreat. So we treat the patient and we watch the patient, and continuously we're asking the question, do they need more treatment? With the available software, such as the Zeiss Forum Glaucoma Workplace, we can look at the rates of change over time. And before deciding whether you need more treatment, ensure you have entered any really significant clinical information, such as surgery, which is a dramatic intervention. Here you can see that if you look at all of the numbers, there appears to be continued progression. However, when there's been a dramatic intervention, it's important to reset the baseline, and we can do this in the interactive forum Glaucoma Workplace and set a dual baseline. Once that's done, we can see that this person does not need more treatment. No treatment change is necessary. Do I need more treatment? Also, always look at the patient. A change in VFI is not always glaucoma worsening. It could be another disease. Other diseases can impact on the VFI, and they must be excluded. Do I need that treatment? Drops, more drops, laser, surgery, interventional treatments. We have many treatments available to our patients now. Whether it is the initiation of treatment or escalation of treatment, there are risks and benefits of all possible treatments, and the decision will be dependent on the patient's understanding of the relative risks and benefits of the treatment. Our role is to share the available evidence in a way that they can understand it, and so to guide them. But we do not make the decision for them. Another key thing to consider is the stage of the disease process that your patient is at when we initiate or escalate treatment. You can see this is modified from George Spaeth's lecture at the World Glaucoma Congress last year. And he talked about how the disease process is different than from a patient's perspective and from a doctor's perspective. Now, at the same stage of disease, a major difference is that we see things based on our clinical outcomes, depending on our treatment, our examination findings, and patients' outcomes depend on their symptoms. This yellow zone, where you see a problem and the patient does not, is a particular time that the therapeutic index must be judged very carefully. Question 3, am I getting worse? In glaucoma, progression is the rule rather than the exception. The EMGT study showed 60% progressed over 5 years. And the UK GTS study looked at treatment versus no treatment with the latanoprost. And they showed a visual field outcome difference in 2 years. Previously, we thought that functional outcomes would take longer to manifest. And this study really showed that even within a couple of years, we could see visual field progression. So I think that we should assume that the patient is getting worse, and our job is to find out at what rate and how fast. Firstly, you need to do enough examinations to overcome performance and variability. It's always surprising to me that this study by Balchoan, which showed that even for a fast progressor, if you're only doing one field a year and you're a moderate variability performer, you would take 6 years to show true progression in your visual field. And if you did 3 a year, it would take 2 years. There's some idea now that clustering of visual fields at diagnosis, and then again, if you think someone is getting worse, may be a reasonable proposal. So we all lose as we age at a mean decibel loss of about 0.1 decibel a year. And we know that glaucoma progression rates are highly variable. The rate of loss varies. Really, we can see that the normal tension patients vary at a lower rate than high tension glaucoma and pseudo-exfoliative glaucoma. Rate of change, rate of loss is more important than just significance of loss. So someone who's definitely getting worse, but at a slow rate, like minus 0.2 decibels a year, that's just twice the rate of aging. That person will take 150 years to go blind in that eye. Someone who's rapidly progressing at, say, minus 2 decibels a year will go normal to blind in 15 years. So where is your patient in that progression rate? This study in Portsmouth, which audited the clinic patients, found that about 30% were rapid progressors. I think our job is to work out who the rapid progressors are, but also not to forget that statistical progression, such as this eye, where there is real loss, but it's not going to be a significant progression, because this will not lead to any significant loss of functional vision in this person's lifetime. The loss to function may be subtle and slow. Patients may manifest in their activities, events, and behaviors. And the visual field in the better eye may determine disability. The location of loss may also have an impact on function. Interestingly, if you lose your superior field, this has more impact on your near vision, such as reading. And if you lose more inferiorly, you have more difficulty with mobility. I'll just speed up a little bit. I think I've gone over time. So driving is a really important function in my country. You really can't get anywhere without driving. So we do quite a few estimates. Now, the fifth question is, will I go blind? This is something that I'm often asked at diagnosis. And even if it's never asked, patients are wondering this. I often bring this up at diagnosis, mostly when I can reassure the patient that it's an unlikely outcome. Unfortunately, patients still go blind from glaucoma. And so we need to be aware of the definition of blindness because it can give different benefits. In Australia, it's a constriction to within 10 degrees of fixation in your better eye. Who goes blind from glaucoma? People from developing countries, undiagnosed glaucoma, bilateral glaucoma, and certain types of glaucoma, such as angle closure. Now, the final question, what can I do? Patient wants some hope. So we need to empower our patients as much as we can. So do adhere to treatment. Do look after your general health and well-being. And on that note, we know that glaucoma is associated with many systemic diseases, such as diabetes, metabolic syndrome, and the list goes on. These have sometimes been called the diseases of civilization or the plagues of prosperity. These chronic diseases often occur in clusters, and we see them in our patients all the time. And this multimorbidity has led to some people to look at the possibility of a shared pathogenesis. Your genetics are the seed. However, the soil that the seed lies in is your metabolic health. And together they determine the diseases that you manifest. Metabolic health is determined by environmental factors, and arguably the most important environmental factor is diet. Hyperinsulinemia, insulin resistance, and the resulting inflammation have been implicated as possibly the root cause of these diseases of civilization. Whether glaucoma is another disease of civilization has mechanistic merit. And so then we may hypothesize that changing our eating pattern has potential to impact on diseases. Anyway, food for thought. Lastly, I want to share some wisdom from George Speight. The operation was a success, but the patient died. It's a thought that comes to my mind whenever I think we may have missed the point. Remember, we're treating patients, not a number, not an IOP, disc or field, and what our primary responsibilities to our patients are. And on that note, thank you very much.
Thank you, Dr. Rydia. That was a really enlightening talk on a different perspective of how we as glaucoma specialists should manage patients. The whole week of World Glaucoma Week was about increasing awareness in the public on glaucoma. But I think we as glaucoma specialists should also be made aware that there is a different perspective of the patient, their fears and their apprehensions and their anxiety in living with glaucoma. We go on to our next speaker. I would like to introduce Professor Dr. Liza Shamini, our own glaucoma flower in Malaysia. She is a consultant ophthalmologist, the head of glaucoma service in University Science Malaysia, and she has nearly 20 years experience in conducting clinical and molecular research, especially in glaucoma. And she has completed 20 international, national, and university-based research and published more than 100 papers in various journals worldwide. She is currently the Vice President of the Malaysian Glaucoma Society, committee member of the Malaysian Society of Ophthalmology, and a member of Asia Pacific Academy of Ophthalmology Fellowship Standing Committee, Malaysian Society of Human Genetics, Asia Pacific Glaucoma Society, the College of Ophthalmology, and the Asia Eye Genetic Society and the Asia Pacific Eye Genetic Society. She's the founding editor of Malaysian Journal of Ophthalmology and a member of editorial member of the Therapeutic Advances in Ophthalmology and the Open Ophthalmology Journal. I welcome you, Professor Dr. Liza Shamini.
Thank you so much, Associate Professor Dr. Samsia. I was very delighted to listen to Dr. Rydia's talk just now. It's really eye-opening. And basically, my talk is actually a continuation from the questions number 6. What can I do? What the patient always asks you. Before that, I would like also to welcome other speakers. From Singapore, Professor Ontin, and also Dr. Verna from Indonesia. So this is our first tripartite, and I hope this is going to be sort of an annual event for the coming year of World Glaucoma Week in the 3 countries. Okay, let's go into my talk. The title is Why Will Lifestyle Modification Change the Course of Glaucoma? Right. This is my financial disclosure, but none of these actually take part in my talk today. All right. Treatment of glaucoma, as we know, has been mentioned by Dr. Rydia, medical, laser, and surgical. Whatever the mode of our treatment, the aim is still the same. We want to lower the IOP and then to prevent further progression and hopefully maintain the quality of life. But this is rarely or very minimal emphasis have been given in terms of quality of life. But we know then and again, most of our patients, even if they achieve target pressure, the progression still happen. And most of the time, they will ask you, what can I do, doctor, to help me? And to make sure there is no progression. Okay, so this is where the issue of lifestyle modification may come in. The lifestyle modification will include diet. So this is the issue, you are what you eat, physical activities, and other behavioral changes, okay? And as we know, healthy lifestyle have been very helpful, especially in many chronic non-communicable disease, especially hypertension, heart disease, diabetes, and a lot more. And even, especially in cardiovascular disease, this lifetime modification was identified not only as primary prevention, also as secondary prevention. We know the changes in life for those patients who has developed ischemic heart disease has actually changed the prognosis and morbidity of the patient. Will that be the same for our glaucoma patient? Can lifestyle modification be part of primary and secondary preventive measures for glaucoma? This is the postulated pathogenesis or possible mechanism how the lifestyle changes can help in terms of progression and development of the disease. Can you see now is diets, omega-3 or fatty acid from the fish, physical activities, and also improvement in terms of quality of life that actually will improve their oxidative stress, and this may all help in terms of retinal ganglion cell damage. All right. Now, let us look at dietary modification. Right. We have been talking about dietary modification, and a lot of our patients been asking us, what can I eat? What will be good for my eye? Is carrot good? Or is drinking coffee is not good? So is there really a strong established association of diet and risk factors as for glaucoma? As you know, behavior change strategies change according to age. And you know glaucoma is age-related diseases. So as you age, your choice and preference of food will change. Furthermore, as you age also, there is coexisting systemic comorbidities such as diabetes, hypertension, and a lot more. So with that, they will come with changes in food preference, basically due to your palatability when you get old, when your sensory perceptions of food will be different. And there are also other factors affecting choice of food. For example, as you get older, you are retired, pensioner, so you will have some financial difficulty, so the choice of food will differ when you were in the working age group. And at the same time, it is affected by health and nutrient belief, culture, and religious. With that, we have conducted what we call Malay glaucoma eye study that we call as MAGIS, whereby this study basically are studying all the possible modifiable risk factors for patients with primary glaucoma. And we just choose Malay because, as you know, there is also culture and religious implication for each of the population in the world. So what we have studied is the diet, physical activity, and cigarette smoking. And this study is divided for now for two phases, phase 1 and phase 2, whereby this phase 1 was between 2017 to 2020, and now we are in the phase 2 of the study, whereby based on the phase 1, we identify these modifiable risk factors as per the cross-sectional study using several questionnaires, and around 500 patients were involved. And whatever the finding from phase 1 is later on used as randomized control trial study in the phase 2. Basically, we try to introduce the intervention in terms of diet changes, exercise, navigation, and also reading rehabilitation. Right. These are the evidence in terms of the dietary intakes that were, these are all the huge study, I think it's around 5 study that involve different population, but none of them are actually Asian. Perhaps maybe Wang 2030 could be involve some of the Asian patients. And the definition of glaucoma tend to vary. You can see here some are based on diagnosis, some based on self-reported. So whatever it is, these are all with a large number of patients. So based on this study, the meta-analysis has shown that vitamin A, vitamin B1, C, and E actually do provide some protective effect against the risk of glaucoma. Right. So based on other study, for example, we can see the finding is still inconclusive, whereby some of the study believe that the green leaf vegetable, cabbage, and a few others reduce the risk, but the other study do not find any association with this high intake of vegetables and fruits. And based on our study, we did find that the vegetables and fruits, local fruits, does provide some protective risks against glaucoma, but none of these are actually significant for progression of glaucoma. These are based on what we have found in the phase 1. So we have tried a pilot feasibility study on around 60 patients, whereby they were given 200 grams of papaya daily for 3 times a week, and for 3 months. And what we found that there was significant reduction of IOP in patients who actually taking frequent intake of papaya daily. And there is also some improvement in terms of retinal nerve fiber layer thickness, but there is no changes of optic nerve parameters. But we have not really go through into the full-blown of randomized control trial yet. All right? Okay, then we look into fish, which is believed to have a lot of omega-3 that will actually reduce neurodegenerative or retinal ganglion cells. What we found is the fish, especially marine fish, reduce the risk of glaucoma by 3-folds, and anchovies actually reduce the risk of progression by 4.1-fold. And based on previous study, there is still inconclusive with some study find the benefit of fish, but some do not find anything on the association between fish intake and glaucoma. Now let us look into coffee and tea. This is the most favorite beverages in the world. As we know, coffee and caffeine basically transient increase of IOP of 2 mm mercury within 2 hours post caffeine drinking. Based on our study, we found that frequent intake of coffee and tea actually increase the risk of glaucoma and also increase the risk of progression. Our previous retrospective study also conclude that frequent drinking of coffee increase the risk of progression to 8.1-fold, whereby other studies, especially Kang et al., based on a huge study, they found that higher transient elevation of IOP is more significant in Jew age patients and those with family history rather than with other type of glaucoma. Right. And how about the physical activities? As what Dr. Rydia has mentioned just now, they tend to be less active, they tend to self-isolate. As you know, happy aging include being physically active. So keeping active, including exercise, is very important. Right. What we found from McGee's 1, we found that moderate physical activity reduced the risk of glaucoma and severity of glaucoma. But at the same time, the severity constricted visual field limit the physical activity of many of our patients. But in this study, we do not specify any specific exercise that will be good for glaucoma patient with constricted visual field. So, and in McGee's 2, we try chair back-based exercise for a year. Those patients are supposed to do twice a week for 1 year. Unfortunately, this long-term study do not find any significant impact on IOP or even the risk of progression of the disease. So now we are still searching for the best exercise that will be safe and user-friendly to the older adults population with constricted visual field. Right. You know, cigarette smoking has been implicated in many diseases, including chronic non-communicable disease and also cancer. Right. So far, there is inconclusive evidence to say cigarette smoking has increased the risk of glaucoma, whereby some studies said there is a risk factors, but some studies say there is no association at all. Whereby in our study recently, we found that it's more actually affected by the sex predisposition. Reason being is in our study, we include POAG and PACG patients, and we found that active smoking impose an increased risk of POAG, whereby passive smoking, whereby in this study, a lot of female patients with PACG was involved, increased the risk of PACG by 6.8-fold. Right. Not just asking them to be more active, eat healthy, and also stop smoking, but I think it is important for them to improve their own quality of life even after they have developed glaucoma. So based on what Dr. Rydia has presented just now, the main problem is actually driving, mobilization, and reading. Similarly, based on our initial finding, we found driving, mobilization, and reading is the most important factors affecting their life. What we are doing right now, we are trying to create a module for rehabilitation for mobilization and also reading. Recently, we just concluded one study whereby we use a rehabilitation mode used for stroke patients, Chessington Occupational Therapy Neurological Assessment Battery, for 6 months, whereby they will teach how to navigate themselves at home in a simulated environment, but we do not find any significant difference in terms of their step count, their ability to walk around, but they are reduction of mean IOP after 6 months of follow-up. Mind again, this study was conducted during the pandemic, and perhaps I think due to the lockdown, they tend to be less active. Right. There is also study implicated that sleeping position, as you know, sleeping position at night will increase the IOP, and they postulated perhaps the sleeping position will actually help into reduction of IOP and progression of the disease. So they found that all recumbent position cause increase of IOP. The best is to put up in a supine position, but there was no effect on the progression of the disease. Okay. As a conclusion, I think this life modification is very important as a very good potential as primary prevention of glaucoma, and definitely it is really helpful once you have glaucoma for you to have a better quality of life. But however, we need more longitudinal study, prospective study in the future. All right, thank you. This is my acknowledgement to all my co-researcher references. Thank you.
Thank you, Prof. Liza. Now we know what to tell our patients, what to do. So that's a huge amount of information there. Before I introduce the next speaker, there's some housekeeping announcements to all audiences. If you have any questions, you can type your questions in the chat box and we will gladly answer for you. Now, the next speaker is Dr. Virna Dwi Oktariana, all the way from Indonesia. She's here with us live. And Dr. Virna is currently the chairperson of the Indonesian Glaucoma Society. She completed her ophthalmology training in 2004 and she pursued a doctorate degree and graduated with a PhD in 2016 from the Faculty of Medicine, University of Indonesia. She did a fellowship in glaucoma and a few short courses in the Royal Victoria Eye and Ear Hospital in 2007 and Royal Perth Hospital in 2011. As part of a PhD project, Dr. Virna patented the Virna glaucoma implant, which is now widely used in Indonesia. She is currently the lecturer in ophthalmology in the University of Indonesia and a visiting lecturer in University of Sam Ratulingga in North Sulawesi. I welcome you, Dr. Virna Dwi Oktariana.
Thank you, Associate Professor Dr. Samsia, and thank you, the committee, for inviting me in this talk. Actually, I really enjoy the talk by Dr. Rydia and also Prof. Lisa. It's really nice to have all of this talk today. So I will share my talk today. Hopefully, it will just sharing a bit about the knowledge regarding the glaucoma implant in my country. Thank you, and this is my hospital, Cipto Mangunkusumo Hospital, and this is our building, ophthalmology department, we call it RSCM Kirana. And we know that as a glaucoma management, as already mentioned by two previous talk, there is a medication, laser, and surgery. And we're facing with refractory glaucoma, and that usually we end up with the glaucoma drainage device. The development of this glaucoma drainage device, actually at that time, we know that we have an increase the need of glaucoma implant surgery, but then the availability is very limited. And then we also need for a low cost for the glaucoma drainage device. And we think that it should be easy to manufacture and sterilize, and also easy to insert and with a minimal complication. And at that time, we also tried to design it for Indonesian eyes with the size and shape. We tried to make it implanted between the muscle, under the muscle like a bar felt. And then we tried to measuring the distance between the superior and lateral rectus muscle to try to put it in an easy way for the glaucoma drainage device. And then also we think about the area of diffusion. And then for the implant of the materials, we choose the polymetal methacrylate at the moment, at that time, because we know that it is, has been used as an implanted biomaterial in many other surgeries. And also it is the first IOL compound with long biocompatibility profile. The smoothness of the surface, and we know if the smooth the surface is, and then it will be less, we thought that it will less make the fibrosis. And also it is easy to modify, and then less expensive. When I planned the design, I discussed this with Professor Bill Morgan from Lions Eye Institute in Perth. And then also we tried to design it as simple as possible. And then also we discussed it with Rohto, because we know that at that time only Rohto is able to have a manufacturer to have a glaucoma drainage device. So we discussed about the plate, the tube, and then also the glue. And then we have this design, and then we do it. We plan the research in the animal study, and also we do the material examination, and also we do insert it in the advanced or end stage glaucoma patients. So we evaluate the biosafety and biofunctionality. We examine it in the rabbits and also the materials. In the rabbits, we evaluate the inflammatory reaction in the day 5 for acute condition and also 30 days for the chronic condition. And then we evaluate the foreign body reaction of 2 biomaterials in the day 60. And then also we compare with other study that use another GDD like Ahmed. And also for the material, we compare pre and post implantation. We evaluate using the atomic force microscopy, and also we evaluate using Fourier transform infrared spectroscopy, and also gas chromatography mass spectrometry. This is the implantation in the rabbit's eye, the procedure. I did it in the another institute with the veterinary. The institute has a veterinary hospital there, so I could perform the rabbit surgery safely. This is the place where I performed the surgery with Professor Bill Morgan at that time, and this is after I do the enucleation of the rabbit eye, and this is the macroscopic condition after the implantation in the rabbit eye. And we fortunate that we have a fortunate that we have a rabbit with a glaucoma. There is one rabbit with a glaucoma. The other eye is actually good, but the other eye has a ophthalmic eye. And then preoperative IOP is about 22 millimeter mercury with feline scale, and then the cornea is very hazy. The cornea diameter is very big as well. And then after the postoperative IOP is very low, the pressure is very low, and then I could see the cause of the glaucoma in this rabbit is actually is a congenital anomaly, because the rabbit has a coloboma of the iris. And then we also examine the day 5 and then the day 30. This is the macroscopic condition in the day 5, and this is the day 30. And then we compare it also with Ahmed on the day 30, and we evaluate the foreign body giant cells, and we compare it between the study by Jung using the Ahmed and then our study. It's quite the same. And then also we measure the capsular thickness of the implant in the superior part and the inferior part in the day 30 and 60, and we compare it also with Ahmed, and then on the 60 day as well. And we got that in Ahmed in the 60 day, the roof of the bleb, so it is the superior part, is about 458 the capsular thickness, and then in the floor bleb like us, he got like about 233, and I got about 242. And we also measure the atomic force microscopy for the roughness or the surface of the implant. And then we have, after the implantation, the roughness is about 22.9 nanometer. We compare it also with other study with Ahmed or Barfeld and also Molteno. Maybe the nearest one is with the Molteno. And then also we compare with the Fourier transform infrared spectroscopy, and we got that after the implantation, it is quite the same, almost the same. The reference of the PMMA spectra for the condition without the implantation is still the same. And then after all of the rabbit study, we try to have ethical clearance and then it's actually granted on July 2015. At that time, we have 2 subjects on strict supervision for 1 month. We implanted this GDD on these 2 subjects, and no significant or severe complaint or complication. And then number of subjects were increased to 10 subjects. And then there is an additional also 3 subjects for prepared in case of there was a dropout along the research. The subject collection was done until December 2015 for the first study. And we observed about 3 months to evaluate the clinical examination, the ASOCT, MMP2, and TIMP2 assessment. And 14 subjects followed 3 months observation. But unfortunately, 1 subject didn't come on the follow-up on the 90 day. And this is the condition on 60 days and then also on 90 days. And this is the ASOCT examination. So from the 2015, from March 2015 until 2022 now, we have clinical trial phase 1 animal and material study on March 2015 until June 2015. And then we have a clinical trial phase 2 for advanced glaucoma patient on August 2015 until September 2017. So after we follow up this 15 patients for a year, then we added more patients. After we could see that this GDD is safe, then we added another patient. And then also the Indonesian Ministry of Health granted the distribution of permit for this GDD on May 2019. And then I also do the teaching and encouraging how to do the glaucoma implant. And now maybe already like about 600 patients has this implant. We have collected 220 patient data for about 1 year follow-up in Cipto Mangunkusumo Hospital. We have 143 male patient and 77 female patient. So it's about 220 with diagnosis is very varied from the secondary glaucoma to primary glaucoma. As you see that most of our cases is silicone oil with about 50 cases. And then the failed bleb in open angle glaucoma, about 40 cases, and also neovascular glaucoma, about 30 cases. And then this is the median IOP per visit from the preoperative until the 12th month. We have a quite high IOP for our patients, about 37. And then until the 1 year follow-up, we have the IOP about 14 millimeter mercury. And then the success rate for the 220 patients in 1 year follow-up, we could see that complete success about 53.6%, and then the qualified success about 33.6%. So it is about 87.2% on the success rate, and then 12.7% in a failed case. And we have like a number of extra procedure for the patients during this 1 year follow-up. Usually we have 7 with usually in the first month we have like a patient with viscoelastic injection during the first month follow-up. You know that because this is the non-valve, sometimes maybe the tight up of the tube is not tight enough, so there is still leakage in that. So there is a shallow or even sometimes flat chamber, so we have to adding more viscoelastic in that case. And then also we perform like a blood aspiration and 5-FU injection subconjunctivally during the hypertensive phase to help lessen it, like maybe in the 3 or 6 month follow-up. And we have also like some patients have a repair of the expose of the tube, but for the tube explantation, maybe only about 2 or maybe about 3 cases for the tube explantation. But mostly we have, because the patient mostly related with the post-retinal surgery, sometimes the conjunctival condition is not that good. So that's we suspect that probably that's why the condition of the conjunctiva is not causing the tube explantation on the patient. But also we have a patient with expose of the tube, and then we have to do the repairing of the tube expose. In summary, we know that PMMA implant has smooth and surface and good biosafety. And then in the earlier study, it proven effective in the rabbit eye and glaucoma subjects. And in the recent study, the overall success rate was about 87.2%, comparable with other GDD. And then the post-operative management may need thorough observation and additional treatment as needed. And actually, until now, we still do the follow-up for the patient. From the we actually have like make the data that every patient that still do the after the surgery, we still do the collecting the data and to follow up the condition of the patient. Thank you very much. This is our team in the Bogor Institute, and then this is when I have my PhD presentation. Thank you very much. I will stop myself.
Thank you very much, Dr. Verna, for taking us on your journey from a clinician scientist view of bench to bedside. It always amazes me how you got to this point, and lots of respect to you. Okay, I'm tasked today to introduce our final speaker or anchoring speaker. He really needs no further introduction, I think. Professor Ong Tin is the key opinion leader worldwide in all matters associated with glaucoma, particularly angle closure and ocular genetics. Professor Ong Tin is currently medical director of Singapore National Eye Centre, and he's also in the academic chair and also distinguished professor in the Duke and US Medical School. Professor Ong Tin is also responsible for training 3 of our glaucoma specialists in Malaysia, including myself. And I'm also happy to call him a friend as well. So without further ado, I would like to introduce Professor Ong Tin to speak on precision medicine in glaucoma, lessons from pseudo exfoliation. Professor Ong Tin.
Good afternoon, ladies and gentlemen. I would first like to thank the organizers of this conference for inviting me to give this talk. My title of my talk is Precision Medicine in Glaucoma, Lessons from Pseudo Exfoliation. My name is Tin Ang and I'm from Singapore. I have no relevant disclosures. As I said, I come from Singapore, and currently I'm the medical director of the Singapore National Eye Centre, and I'm also the chairman of the board of the Singapore Eye Research Institute, and I hold the appointment of professor at the National. The topic of my talk is on precision medicine. What is the meaning of this phrase? Well, it's basically using information about a person's genes or proteins to prevent, diagnose, or treat disease. And overall, to provide a more individually tailored management that works best for that particular patient. A very famous example of precision medicine is the BRCA1 mutation for breast cancer and other ovarian cancers. And this was very famous because of Angelina Jolie. She is a carrier of BRCA1 mutation, and if you carry that mutation, you have almost 90% risk for getting breast cancer and 50% risk for ovarian cancer. And Angelina Jolie, as you know, a very famous Hollywood star, underwent prophylactic bilateral mastectomy just to prevent the risk of getting breast cancer because of a strong family history of breast cancer in her mother and her sisters. So this is a very famous example of precision medicine. What about precision medicine in glaucoma? Before we delve into this topic, we need to talk a little bit about glaucoma genetics. So in glaucoma genetics, there are actually different forms of glaucoma, which are either inherited in a familial fashion, such as an example you can see in this pedigree, where it's a Mendelian inheritance and it's a single gene disorder. And this is the famous example is that of myocilin, which is responsible for about 5% of primary open-angle glaucoma cases worldwide. And this contrasts to most adult onset disease glaucoma, in which the genetic risk is not as strong as a Mendelian disorder. So Mendelian disorders have very strong genetic risk, and they usually typically occur early onset. And for adult onset glaucoma, most of them are susceptibility genes. So that means they are not directly causation, but they contribute to susceptibility of developing the disease. Myocilin, as I mentioned, was the first gene ever discovered for glaucoma, and this was found in the family shown in the picture by Ed Stone's group in Iowa. And this gene was found to be inherited in an autosomal dominant fashion in this family. Since then, many studies have found different genotype-phenotype correlations. For example, these mutations listed here, if you carry these myocilin mutations, you get a very severe form of glaucoma with early age of onset, high IOP, and resistance to medical treatment. This is an example of a rapidly progressive glaucoma. And if you get this other mutation in the myocilin gene, you get a very less virulent form of disease with very slow progression. So certainly for familial glaucoma with myocilin mutations, you can develop so-called precision medicine approaches to certain patients with these mutations. As I mentioned earlier, the vast majority of glaucoma cases are actually complex and not inherited in a Mendelian fashion. And to find genes for such complex glaucoma, we used to do something called genome-wide association studies, or GWAS. And in this approach, you are running markers called polymorphisms across the entire genome in a case control approach to find genetic risk factors. And these are typically with odds ratios typically below 2.0. And this is a case control approach. So we move into angle closure glaucoma, our group in collaboration with multiple other groups in the world, including those in Malaysia. We did 2 angle closure GWAS and found there are about 8 different genetic loci for angle closure glaucoma. So these are risk genetic loci, which means if you carry these changes, you have between 20 to 30% higher risk of developing the disease, or an odds ratio of between 1.2 to 1.3. Now, these angle closure glaucoma genes we don't know exactly how it's involved in the disease. We don't know whether they are involved in developing the angle narrowing, or are they involved in developing risk for glaucoma. So we did a study a couple of years ago when we looked at these angle closure glaucoma genes to see if they were associated with narrow angles or PACS. And we found very interesting results. 2 of the 8 angle closure genes were also associated with PACS, which means that they are probably related to the narrow angle configuration. But there were other angle closure genes which were not associated with PACS, but they are associated with angle closure glaucoma. So it raises the question of whether these genes are involved in progression or perhaps in development of the glaucoma aspect in angle closure glaucoma. And one of the 8 genetic loci, EPDR1, was also found to be associated with more severe disease. This was a study we published in 2020, in which we think it's a biomarker of angle closure severity. We move on now to exfoliation or pseudo exfoliation, and this is a fairly common disorder, first described by Lindbergh, in which he found grayish flakes on the lens and pupillary margin. We know exfoliation syndrome is a major cause of visual loss and a major cause of blindness as well. And we, as cataract surgeons, we fear finding patients with exfoliation on the table because there's a greater risk of cataract complications, particularly zonular instability and poor pupil dilation. and it's blinding disease because of the development of glaucoma. People with exfoliation syndrome have higher risk of developing glaucoma. At least 30 to 50% of them do develop glaucoma. And if you look at the genetics of exfoliation syndrome, we've been involved in several different studies, but not in the first one, 2007, where they found the first gene for exfoliation syndrome called LOXL1. And this was found by a group in Iceland. And basically, LOXL1 is an enzyme involved in cross-linking of elastin and collagen, and is involved in the formation of ECM fibers and stabilization. So it makes sense, and because it's involved as a connective tissue disorder. And LOXL1 is a very strong risk factor for exfoliation syndrome, one of the strongest genetic effects for any complex disease, but there's no clear link with phenotype. And since then, we've been involved in several studies looking for exfoliation syndrome genetic risk factors. In 2015, we published one. We found a gene called CACNR1, which is the calcium transporter gene. In 2017, we led a global consortium of 36 different countries and found 5 different genetic loci for exfoliation syndrome, but none of them are really related to phenotype as yet. And the latest findings, which we found only in the last year or so, was using an approach called whole exome sequencing, in which you sequence the entire coding region of the genome or the exons, and looking for rare mutations of high penetrance and high risk that are missed by GWAS. And the coding sequence of the genome actually is only about 1% of the entire genome. And using a whole exome sequencing approach, you're able to just sequence those coding areas to look for protein changing mutations. And this is what we did. In 2021, we did a very large whole exome sequencing study of more than 10,000 cases of exfoliation syndrome from Japan, Singapore, and other countries with multiple replications. And we found mutations in a gene called CYP39A1 to be very strongly associated with exfoliation syndrome. And CYP39A1 is a gene involved in cholesterol metabolism. It's the enzyme mediating the change from hydroxycholesterol to dihydroxycholesterol. And this is a very interesting finding because we never thought that cholesterol metabolism is involved in exfoliation syndrome. And this gene was also found to be in the liver, in the choroid, ciliary body, the lens, iris, and the optic nerve. And particularly, it was very strongly found in the epithelial layer of the ciliary body, the pigmented epithelium, as well as the vascular endothelium in the iris and the retinal pigment epithelium. So these are all areas which is involved in exfoliation syndrome. And in fact, when we looked harder, we actually found that patients with exfoliation syndrome have significant stains for esterified cholesterol at the basement membrane of the pigment ciliary epithelium, something that not found before. And that's because nobody looked at it, nobody looked for cholesterol in the eye. And here you can see the direct role. It's found that the people with CYP39A1 expression is found to be lower in tissues of patients with exfoliation syndrome compared to those without exfoliation syndrome. And what about the phenotype of such patients? Well, we recently looked at the phenotype of the most common CYP39 mutation, which is the G204 mutation, found in almost 1% of Japanese patients with exfoliation syndrome. And this is a retrospective case control study. We studied 35 Japanese patients carrying this G204E mutation in CYP39A1 compared to 150 patients with exfoliation syndrome of Japanese patients without any mutation. And these patients were followed up, had a follow-up time which was comparable. In fact, it was longer in those patients with CYP39 mutation compared to those who were normal. And what we found was very interesting. Well, let's look first at the demographics. You can see here that there were similar number of patients, males and females, and similar age of diagnosis, as well as history of hypertension and hypercholesterolemia. But if we looked at the phenotype of these patients of exfoliation syndrome with this mutation, we found, for example, that patients with the mutation had 5 times greater risk of developing exfoliation glaucoma, 7 times greater risk of developing blindness, and also a much higher rate of glaucoma-related blindness, higher need for glaucoma surgery, higher peak IOP as well as greater disc cupping in those patients with the mutation compared to those without the mutation. We also looked at just comparing exfoliation glaucoma patients, those with the mutation versus those without the mutation. And even more surprising, within exfoliation glaucoma, those with the D04 mutation had higher risk of blindness, as well as higher need for surgery and higher peak IOP. So even within the glaucoma group, we found greater severity in patients with this mutation. So this is the first study showing a link between rare genetic coding sequence variants and severity of glaucoma. And it's very interesting because we found that these patients with this mutation had a much greater risk for glaucoma, blindness, a more aggressive disease, needing lower target IOP and more frequent monitoring. So this is an example of precision medicine, because if you have such a patient, you need to treat them more aggressively, monitor them more closely. And this mutation is fairly common in the sense it was found in about 1% of all Japanese people with exfoliation syndrome. So we wonder whether in Japan now, everybody with exfoliation syndrome who's detected should be screened for this mutation. And if they have this mutation, they need to be treated more aggressively and certainly monitored more aggressively. But probably there's no benefit of nationwide screening of these patients just for population-wide screening, because it's not that common in the whole overall population. But certainly it will be beneficial in Japanese patients with exfoliation syndrome. So of course, this was a retrospective study, and we looked at patients retrospectively, so there could be some heterogeneity in terms of patient data collection as well as management protocols. We didn't have OCT or compliance data, and this is only one of the several CYP39A1 mutations that we found. So we only looked at this one mutation because it was the most common, and these were, of course, only Japanese patients. And this very interesting paper is actually coming out in Ophthalmology, actually I think in this month or next month issue. So in summary, I've described to you a very interesting finding on exfoliation syndrome genetics. So we found, firstly, an association of CYP39A1 and a cholesterol gene, this is the latest finding, involved in exfoliation syndrome. And those who carry this particular G204E mutation had much higher risk for exfoliation glaucoma, higher risk for glaucoma-related blindness, and a greater risk for surgical intervention. And certainly, they have a very severe phenotype, which needs more careful monitoring and probably more aggressive treatment. And this is an example, as I said earlier, of precision medicine in glaucoma. I'd like to acknowledge here some of the sources of funding that we've had over the years for all these studies. Particular acknowledgement to Dr. C.C. Kaur, who's our geneticist leading this group, and Dr. Minio Ozaki, who's our Japanese colleague who set up the Japanese Exfoliation Syndrome Consortium, and Dr. Wang Sin-chun, who helped identify all these rare variants, and Dr. Katharina Bell, who did the study looking at the phenotype of these patients. And these are the Exfoliation Syndrome Consortium from Japan. We have all these centers and collaborators listed here. And we had lots of fun over the years. Of course, with COVID, we haven't met up for many years, but you can see here all our social activities, having fun in discovering all these new findings in exfoliation syndrome. I'd also like to acknowledge all the other exfoliation syndrome international collaborating network. You can see here all the countries involved. It's been really a great pleasure working with everyone and developing all these friendships and collaboration. Thank you for your attention.
Thank you. Thank you very much, Prof. Ang Tin, for the wonderful lecture. Now we are into our Q&A session, and all our panelists are on live as well. For the first question, it's from Dr. P.K. Chen. Probably, Rydia, because Dr. Rydia Lim spoke about lifestyle and the patient's question, the patient is asking, the participant is asking, does taking the glucosamine increase the risk of IOP, high IOP? But again, Dr. Lim, to everyone's information, Dr. Lim has just delivered a Gillies lecture in the recent NZEX, And she has spoke about like insulin resistance and like lifestyle changes in glaucoma, and and she is a ketogenic diet follower herself, and with the wonderful results. Probably Dr. Lim can take us through this question and other lifestyles or diet advice from there.
I'm not sure really about glucosamine. I
Dr.
think
Rydia, you're
that.
muted.
Oh, can you hear me?
I could hear you.
Oh, can you hear me?
Yeah,
Okay.
thanks.
Yeah, I'm not sure about glucosamine. I think that it was really interesting to have the talk from Professor Lisa after me, and have that ongoing discussion about lifestyle and diet. The diet's a really difficult thing to study because there's been a lot of epidemiological studies, but interventional studies are the stronger studies are less common. I think that in other diseases such as epilepsy, some neurodegenerative diseases, there are stronger studies. And as you know, Puspa, I'm very interested in particularly the role of carbohydrates and low carbohydrate diets and how they influence certain chronic diseases. I personally feel that a really fundamental thing is what we put into our bodies with our diet, and that supplements are a secondary to a good diet. And while we have many really fantastic work being done on supplements such as vitamin B3, that we should also be giving equal emphasis to diet. So I'd like to see more research being done on dietary changes.
Thank you very much, Dr. Rydia. Going on to the next question on the the question will be to Professor Lisa, actually. It says, congratulations on your study regarding diet modification in glaucoma. I'm wondering whether you looked at Budu consumption. For the international audience, Budu is a very traditional fermented anchovy sauce. It's more like a condiment taken more in the eastern states, and it's very much a favorite there. So the question is whether consumption of Budu has effect on the progression or development of glaucoma. So I'll let Professor Lisa answer that.
Thank you, Proropila. Yes, in my talk just now, I did mention that anchovy sauce anchovies itself reduce the progression of glaucoma, I think around threefold. Yes, we have concluded our study on anchovy sauce. I know anchovy sauce is quite popular in Asia, especially in Thailand, they call it nampla. We concluded the study sort of like we have make our own questionnaire based on food frequency questionnaire, and we found that this anchovy sauce do not play any role in terms of the risk and also progression of glaucoma. Because I think basically because it was taken in a very small amount, as condiment, so it's very difficult to quantify. But for now on, maybe if we have a better study, more of prospective kind of study, maybe we will be able to come with more strong association or more strong evidence to look at the role of anchovy sauce. I'm sure in Indonesia there is also anchovy sauce with a different name, right, Dr. Verna?
Yes.
Okay, I hope that answered the questions.
Any questions from the floor in the room at the moment? Dr. Fang has a question.
Hi. Thanks to all our speakers. Hi, Rydia, Verna, and Tin. Thank you for participating in our tripartite conference. And also thank you to all the chair, all the wonderful ladies in front, Puspa, Nolina, Samsia, and Liza. I would like to ask a question to Dr. Verna. For your implant, do you use mitomycin C?
No, Doctor. I didn't use mitomycin C.
So for all the patients, you don't use mitomycin C?
No.
Yeah. Okay. Do you have a comparison between the results of your implant with Ahmed?
Actually, there is a study by Professor Ike in our hospital about, she collected the data for the Ahmed implant about, I forget how, actually Prof. Ike is in this meeting as well. I forget how many subjects she got at that time because it is like a descriptive study. So she collected from retrospective data from the medical records, but I forget how. But I only remember that the success rate is about 70 to 80% success rate for the all of the Ahmed implant that has been done in our hospital, Dr. Fang. So that's why I said it is quite comparable.
Okay, my next question is probably to Professor Ong Tin. Hi, Tin, how are you?
Hello, good to see everyone.
So just a quick question about your amazing, as usual, study on the pseudo exfoliation and its association with, you found an association with cholesterol. Was there any, did you look into actually systemic cholesterol levels, whether it was associated with any, is it HDL or LDL cholesterol? So was that significant in the patients as well?
That's a good question. For the phenotype study, there was no difference in the cholesterol levels between those mutation carriers and the those without mutations. Yeah. But we don't have, because it was an ophthalmology study, we don't have cholesterol levels for a lot of people. Yeah. So it's limited by the power.
May I have a question?
Lisa might have another question for you.
Okay.
Hi, Dean. Yeah, it's very interesting to know that now we found another markers. Is there any replication study done in other population?
For the phenotype study or the CYP39E1? Are you asking about the phenotype?
The genotype and also the genotype.
The genetic finding?
Yeah, the same markers. Is it being replicated in other population? Because you know, most of the PXG study, the one that found in Iceland is rarely found in Asian, or is the one that we found now is replicated in Caucasian too?
Oh yes, in the original JAMA paper, we had multi-ethnic populations. Yeah. The biggest group was from Japan, but there was also many different countries involved, including Europeans, Asians, and you know, there were multiple replications. Yeah. So going back to the cholesterol, what is very interesting is that we believe that along that pathway, it could be possible to actually inhibit the formation of the exfoliation material. And this could be because the pathway is easily targetable, that cholesterol pathway. So we are, of course, trying to see if, you know, we could, there are compounds available which could inhibit along the pathway. And perhaps, you know, if everything works out well, you could have a topical therapy for exfoliation, which would prevent the formation of the material.
But obviously, I think you can't reverse what's already formed, but hopefully you can stop the process from continuing. I mean, that's our hope in the future. Thank you.
May I have a question?
Yes. Oh, yes, Verna, go ahead.
Thank you.
We're open. Panelists can ask each other. The speakers can ask each other, of course.
Yes,
Go
because
ahead.
actually I really enjoyed the talk today. Thank you. First, I want to ask with Dr. Rydia. You mentioned about the progression of the disease. Because in our country, usually we have a quite high IOP, even for open angle glaucoma. Mostly in our open angle glaucoma in Indonesia, we have patient with like 30 millimeter mercury at the time of the patient, the first visit, and even sometimes they have aware when the other eye already blind. So like maybe a very severe condition in the other eye and only has one eye. Is it still like because you mentioned about the progression like 2 decibel per year, it is like mostly quite bad for the patient. But is it related also with the IOP? Because if it is with a high IOP, like in our patient, sometimes we think more aggressive treatment. That's why maybe it's like a dilemma for us. What is your comment?
Yeah, no, I absolutely agree. I think that in many countries in Southeast Asia, this is what you see. You know, you see the patient, they're blind on presentation in the first eye and going blind in the second eye. I think that you really, I don't know if you see a lot of angle closure, but there's certainly a lot of angle closure as well. So, you know, you do have to be aggressive initially. I don't think you have a choice. I think that's one thing that I saw going through places like Cambodia, Laos, and Vietnam. They have a lot of angle closure, and you know, so the first thing would be to see if that's the issue, and you know, don't forget about cataract surgery, lens extraction. I think do more lens extractions. You know, I guess you probably, I don't know if you see a lot of angle closure, but there's certainly a lot of angle closure.
Okay, thank you. And also, thank you, Dr. Rydia. Thank you very much. I also want to ask Professor Liza as well about the coffee consumption. Is it like do you have like a number of coffee or tea consumption that related with the progression of the disease? Because nowadays in our country, the coffee is like a lifestyle, you know. So so many people like they really like drinking coffee. It is like a more or less like a lifestyle for them. So they work with coffee and also sometimes even they could drink like more than 2 cups a day. Is it there is a number with your research about the disease progression regarding with the coffee consumption and also tea consumption?
Thank you, Dr. Verna. Yes, I didn't mention the frequency basically, but the higher frequency we define as those who are taking more than 2 cups per day for both coffee and tea. But we do not look into, you know, coffee and tea. Sometimes it depends on the concentration, the caffeine itself. We do not look into it because our study is just based on food frequency questionnaire. So it's very difficult to quantify in terms of that. Perhaps if we are doing sort of longitudinal study, we can really look into the concentration of caffeine itself on coffee and tea. Yes, I do agree with you. It is like a culture with Starbucks, Coffee Bean everywhere, not to mention the local, you know, cafe and everything. Yes. But I guess those who going to that places are all the youngsters, not the older adults. But as you say, if you are talking about primary prevention, so these people will actually go, you know, later on, especially those with a family history of glaucoma, will develop glaucoma, and we do not know either coffee or tea actually precipitate or predispose them more to get glaucoma in the future. Okay.
Okay, thank you, Prof. Liza. Thank you.
Last question? Okay, perhaps we have one more question from the floor. If none, I've got one question for Prof. Ong Tin. where do you go from now? From the results that you get from the Pseudo X study, what is the next step? Do you foresee in the future that you would either screen certain high risk patients, children of Pseudo X patients, or
Yeah,
genetic therapy?
actually, we are working with a group to actually develop a simple test for that mutation for those patients for Japan. So our Japanese colleagues will probably hope to use it as when they have a newly diagnosed patient exfoliation syndrome or surgical glaucoma, they can run that test to see if they carry that mutation. And this would be a marker of severity. So they will need to follow up those patients more closely or be more aggressive in treatment for those patients. Because it's fairly common, it's about 1% of exfoliation patients in Japan.
All right, so I guess that concludes our tripartite webinar session this evening in Malaysia. I don't know, in Australia, what time is it now, Dr. Rydia?
It's 6:30 at night.
Oh, okay.
On Saturday, yeah.
Okay.
Can I ask you, what is the tripartite? Who are the three parties?
It's actually quadripartite. Rydia is our honorary quad member. It's actually Singapore, Malaysia, Indonesia originally. But we have a special guest from Australia who's joining as a quad to make it a quad.
Oh, okay. I thought it was UKM, UM, and...
No.
It's beyond that, Prof. Ongkin.
It's more international than that. Okay, I think on that note, I would like to thank all our speakers. Thank you very much for joining us from the four corners of Asia. And I'd like to thank my fellow chairpersons as well for this seminar. I think we've all learned quite a lot for precision medicine, really. Generally, that's a common theme amongst all the talks as well. So with that in mind, thank you very much, Tin, Rydia, Virna, and Prof. Lisa.
Thank you.
And I'd like to thank everyone for attending.
you.
Thank you.
Thank you. Bye-bye.
To
And
see you
for
again.
those on
Bye.
mine.
Okay, bye-bye.
Yeah.